What's up, guys, and welcome back to episode 5 of the Mental Wealth Podcast. We're joined in this episode by Dr. Eoin Galavan. Eoin is a clinical and counselling psychologist and is an expert in the area of suicide prevention. Eoin completed his doctorate in clinical psychology in Ireland's prestigious Trinity College, which is recognised worldwide for academic excellence. He is now the clinical lead for the North Dublin Adult Mental Health Clinic, providing suicide-specific assessment and intervention. On top of all that, Eoin has authored several articles and delivered many public talks on the topic of suicide, as well as delivering training to professional groups including the Irish College of Psychiatry and the Irish Association of Counselling and Psychotherapy. It was great to be able to talk about such a perceived heavy topic out in the open with Eoin. I find myself personally anyway, there's like a shroud of mystery or that nobody wants to kind of peel back because it is such a profound thing that affects so many people's lives. So like if you know someone who did commit suicide and you're bringing it up around their family members, or if you know someone who is suicidal, it's very hard to bring it up. You don't really know what to say, you don't know if you can comfort them. I wanted to get some insight in how we could actually bring that up and make it easier to talk about these things instead of it sitting in the background, the elephant in the room. So I really did feel like this was good. And I have an interesting story as well, actually, in the outro, if you want to stick around for that. But yeah, we can leave it there. Enough of me rambling. Reach out to me at coming in here after the fact because I actually said the Instagram handle wrong. It is Mental Wealth Podcast. Back to you, Past 8 on. And let me know if any part of this show resonated with you or not. The best place to get at Eoin is on his Twitter. He's pretty active there and he's always reposting articles. Very interesting around obviously the area of suicide and mental health specifically. His Twitter handle is Galav Psychology. So that's Galav Psychology. Without further ado, here's episode 5 of the Mental Wealth Podcast with Dr. Eoin Galavan. Eoin, welcome to the show.
Hi, Aidan. Thanks so much for having me on.
So what do you think causes someone to get to the stage where suicide is an option?
That's a really big question, and there isn't a really simple, short answer. I wish that there were. It would make working with suicidality much easier if there were. But there's some really kind of good ideas that have been developed over the last couple of decades that might give us a bit of a shape on it. So one of the sets of ideas that I find particularly useful, I suppose, is the idea of Thomas Joyner has a theory called the interpersonal theory of suicide, and he says there's 3 bits to it. So on the one hand, we have things that push us to want to die. And from his point of view, these are things like perceived burdensomeness, so that's feeling like you're a burden on other people. So somebody might say something like they'd be better off without me. And you might also have this idea of thwarted connectedness or belongingness, so a person feeling profoundly lonely and disconnected, and also uninvolved and not valued or valuable or loved or lovable by the people around them. And then as a kind of companion to those things, the acquired capacity to enact lethal self-injury, so developing sufficient fearlessness of bodily harm and sufficient pain tolerance to be able to move through the act of lethal self-injury, which is no small thing to do. If you have these 3 things together in sufficient quantity, there's the potential for a serious attempt or death by suicide.
And what is it that causes the significantly higher rates among certain groups? Like, isn't anorexia sufferers and then like people in the army? What do you think it is that cause those spikes?
There might be lots of different reasons why different groups might have higher rates of suicide. I suppose if you think about the group of people who've been diagnosed with anorexia nervosa, they're typically women and typically younger women, and they have a very high early mortality rate. And this was originally thought to do with the physical consequences resulting from starvation, but actually they have a much higher rate of death via conventional suicide. And Joyner's group did a study where they looked at 240 women diagnosed with anorexia nervosa over a period of 15 years. And in that group of people, there was 9 deaths by suicide. 9 doesn't sound like a big number, but as a proportion of 240, that's really, really high. And it turns out that the methodology that people in that group use is very lethal. And the reason they think that's true is that just to be in that group of people, you have to have developed a very high level of pain tolerance and fearlessness of bodily injury through starvation and or extreme exercise, which means that when the desire for death comes along, the The threshold of fear is different than in the ordinary population. So people are able to move up the lethality spectrum in terms of the behavior they're able to enact quicker than somebody else who wouldn't be in that group. And that fearlessness idea is only one component, I suppose. So there's other reasons. It may also play a part in why male suicide, why men are more likely to die by suicide, that their developmental experiences might lead them to have a lot more kind of pain-tolerating kinds of experiences. So getting used to physical pain, and also the idea that pain is a weakness and that men are not supposed to feel pain, and that kind of thing, coupled with that might be one part of the explanation why men die far more frequently than women from suicide.
Is it 4-1, I believe, is it?
Yeah, that's our ratio, and that ratio is consistent with ratio in other countries.
Okay. And is there any research into the underlying cause of that difference?
There's no kind of answer. There's no one answer. There might be a few ideas. For example, male help-seeking behavior, different kind of rates of aggression. So all violent behavior is more common in men, whether it's self-directed violence or violence towards others. That might play a role. Socialization out of help-seeking behavior and being able to acknowledge emotional pain or psychological pain is something that men really struggle with, and there may actually be some good evolutionary reasons why we don't do that, that men are kind of programmed, in a sense, if you want, to not reveal internal pain to others. So the way we approach helping men should probably be informed by those characteristics rather than expecting men to suddenly be different and start engaging in help-seeking behavior in the same way that women might.
And what are we doing to combat this? And is there any ways we should be addressing this in our mental health services?
Absolutely. The means by which we address suicide needs to change considerably in our health and mental health services. At the moment, we rely on what might be thought of as an illness or disorder focus. So if you go to see your GP and you're referred to mental health care, chances are you'll receive a diagnosis, maybe depression or schizophrenia or personality disorder or something of that nature, or anxiety disorder. There's a whole group of them. And this would be a disorder-specific focus rather than a suicide-specific focus. And I'd strongly advocate that we should have a suicide-specific focus. So regardless of whatever diagnostic category you may or may not meet criteria for, suicidality should be specific enough to get mental health care. That's the first thing. So you shouldn't have to also meet criteria for a diagnosis. Suicide has typically been reduced to kind of symptom status, symptom of an illness.
Okay.
We really shouldn't think of it that way. It doesn't make sense to think of it that way. Suicidality is primarily a crisis of emotion and the mind. And we need services to be able to reflect and manage that in a suicide-specific way. And the big difference between a suicide-specific approach to mental health care and an illness or disorder-specific approach to mental health care is that when we take a suicide-specific approach, we're looking to discover what is the issue that's pushing you to think about ending your life, regardless of what that issue might be. So that might be housing problems, it might be loneliness, it might be depression, it might be a history of abuse, it might be relationship problems, etc., etc. But we prize what your point of view is in terms of what is it that's pushing you to think about ending your life, not prizing a disorder-specific approach where if you're suicidal, that must mean you're depressed, therefore we'll treat your depression, regardless of whether you see yourself as being depressed or not, or whether you see your depression as being part of your suicidality, even if you are depressed. And that separation is really important. At the moment, we have almost like a straight line drawn between depression and suicide. So if you hear about a person who's been suicidal, there's an automatic assumption made, well, they must be depressed. And in that their depression is accounting for their suicidality. Therefore, if you treat their depression, that means you should address their suicidality. It's not an entirely unreasonable idea. However, the evidence base really doesn't back that up much. So standard approaches for addressing depression, whether they're psychological or medication-based, haven't really been shown to make a great deal of a dent in suicidality. So the interventions that have been shown to really kind of make an indent in suicidality are largely psychological and psychosocial, and they're suicide-specific in their focus. And there's actually a fairly small number of them that have a reasonably good evidence base for effectiveness.
Okay, thanks for that. Now, very interesting there. Very interesting. We talked about it there earlier. So, like, there's very much a stigma and like a secrecy around suicide. Like, weak, selfish, and crazy are commonly used terms when talking about suicide. With this negative language, what are your thoughts on it? And do you think it causes people to keep these thoughts to themselves?
It absolutely does, yeah. So suicidality is still highly stigmatized. It's not that long ago that in Ireland it was both illegal and immoral. So it was against the law, and you couldn't get buried in consecrated ground by the Catholic Church if you were deemed to have died by suicide. And that we're only kind of a couple of decades out of that. So there's still a bit of a shadow cast by that. Aside from that, the idea that people who are suicidal are all sorts of negative things is very common. There's a huge amount of mythology and stigma linked to the experience of being suicidal. Which is somewhat ironic given how common an experience it actually is. It's a very fairly ordinary part of the norm of the human condition. It stretches across all societies, across all cultures. Pretty much as long as records of human existence have existed, we have records of people dying by suicide. So it's a very, very common part of the human experience in one sense. Despite the fact that death by lethal self-injury is a rare behavior to occur. And some of the common myths that you mentioned, like if you're suicidal, you're crazy, kind of imply that the idea of death by lethal self-injury must be irrational because it includes self-annihilation. When you listen to the stories of people who are struggling with suicide, it frequently makes a great deal of sense why they would consider ending their lives. And it doesn't stand to reason at all that you have to be crazy in order to consider that. If you think about the myth of weakness or cowardice, which is another word that's often it's the coward's way out, that kind of idea.
Yeah.
That doesn't really stack up against what we were saying earlier about the idea of fearlessness. So the idea of that suicidal behavior requires a certain amount of fearlessness of physical injury just to occur doesn't kind of meet well or doesn't sit well with the idea of cowardice.
Yeah, they're polar opposites.
They're kind of polar opposites. And similarly for selfishness, it's understandable why people, would think that. They're thinking about it largely because of the consequences that death by suicide has on the people who are left behind. And that's an understandable interpretation. But it doesn't really map onto the internal thinking of the suicidal person, who is frequently thinking something like, they'll be better off without me. And while that might be an inaccurate perception, it's inherently non-selfish. They'll be better off is deemed to be for the well-being of others, not for themselves. And if you think about groups of people who might be the most selfish in society, you think about people maybe like who are psychopathic or sociopathic, who are callous and cold and think only of their own needs and utterly inconsiderate of others. That group of people, if suicidality and selfishness were correlated, positively correlated, you would expect there to be a lot of selfishness, a lot of suicidality with people who are very selfish. And actually you find the opposite, that in those groups of people who are deemed to be the most selfish, there's almost no suicide at all. So selfishness and suicidality don't seem to live happily together either. In fact, they seem to be negatively correlated. So there are a lot of myths around suicide that make even acknowledging that that's what you're thinking very, very challenging. And various research studies, depending largely on the way in which suicidality is defined, will have varying population estimates of anywhere from 5 to 20% of the population will think about suicide at some point, which is a massive number of people who visit that space in themselves. Now, the vast majority of those people obviously don't go on to end their lives, and that's a good thing to know as well, that thinking about suicide doesn't automatically mean that you're going to end up dead by suicide. Far from it.
Yeah, and I noticed your wording there around suicide. You never say commit suicide.
No, and there's a bit of a push against that, and it's probably appropriate that push is happening, and that that term links it to an illegal act, which is considered to add to the shame and stigma around it.
Yeah.
So you commit a crime, you commit suicide.
Okay, yeah, I understand that now.
So
yeah,
we should probably move away from that language. Yeah,
definitely. Yeah, I heard that in a lot of your work too. It's still for me today. Say if I brought this topic up with someone I know, like it does tend to suck the air out of the room, you know. And I don't think it should be frightening. As you say yourself, it's everyone's business. So how can we help to end that stigma and spread awareness so that people can bring this up themselves?
Yeah. I think just talking about it is a huge part of it, that if the topic gets some good, and not just talking about it in ways that might inadvertently reinforce it as a frightening topic, but talking about it in ways that bring some understanding to it. So usually suicidal people who are thinking about ending their lives are trying to achieve a number of things. They're trying to end their pain and suffering. They're trying to relieve others of it being a burden. They're trying to get away from the pain of isolation and loneliness, etc. There's a number of things that they're trying to end the hopelessness and despair that they feel. And when we know that, I think that kind of takes some of the mystery and the shame and stigma and maybe some of the fear away from it. Because emotional and psychological pain, hopelessness, despair, loneliness, these are ordinary human experience, and they're human experiences that everybody can relate to in some degree or another. So when we're talking about what do we do about suicidality and how do we think about it, I think we really need to be talking about how do we manage pain and how do we why is our society so lonely and disconnected? Why do people feel so overwhelmed and stressed by their lives? Those kinds of questions, in a way, are less frightening and easier for everyone to kind of grapple with. Because I think everybody would have something to say about that. Every human being who's living in Ireland at the moment would have something to say about those things.
Yeah, it's intrinsic in all of us, definitely. Leading off that, if someone is thinking or consumed by those depressive, suicidal thoughts, where's the first step that they could take?
Yeah, I suppose there's lots of different things that people can do, and that there are lots of things that people do to help themselves when they're struggling. It depends a great deal on the kind of problems that it's pushing them to think about that. But before maybe there's suggestions, I guess I'd like to say a little bit about what I think mental health care should look like, if it is to be improved in terms of, because I'd like to be able to say, well, people should go and get suicide-specific mental health care. But actually, it's quite rare that exists anywhere. So the ideal of what things should be like is actually very rare, and we've a bit of a job of work to do with our health and mental health care system to get it up to kind of speed in terms of what we currently know is effective and helpful in working with suicidal people. So, for example, I use a particular model called the CAMS model. It's the Collaborative Assessment and Management of Suicidality. It's been fairly rigorously trialed and evidenced and researched for about 30 years. And we've used it to develop the North Dublin Suicide Assessment and Treatment Service, and it's also been adopted by other services like the Sure Steps Counselling Service in the Simon community and other services. So that model has certain ingredients in it that make it more likely to be helpful in coming up with a way forward in working with a suicidal person. So, for example, it prizes the perspective of the suicidal person over my perspective as to what it is that's going to help. And there's a collaborative element to it that's absolutely essential. In other words, we work together. So I bring something into that in terms of professional knowledge and understanding, and what you bring into that is your understanding of your own pain and suffering and what you think is most likely to be helpful to you. And that's the guiding line, if you want, or the thing that guides whatever care you receive. It also includes things around risk assessment and risk management and how to do that in a collaborative way, as well as planning out treatment and tracking risk over time. And all these different ingredients are known to be helpful if they're delivered in a particular way. And that particular way is really important. There's a stigma and a fear amongst healthcare staff in working with suicidal people, where people are often treated with contempt, with hatred, with anger or impatience. They're often rejected and pushed away. told, that you're not really sick, and there's really sick people here, and these kinds of things. And that really does need to change. Yeah, no, it's really horrific. And when you think about that and think about what people actually need, which is, a calm period of time to really think about the problems in your life and what might help, they're very different. Also, the environments we push people into are frequently the least possible helpful environments. So, for example, accident and emergency departments, which are flooded typically with people who are suffering from physical illnesses, that we often send people who are in suicidal crises into these environments. And an A&E environment is a great environment to go if you have a physical emergency. So if you break your leg or something walking down the road, that's where you want to be. But a suicidal crisis is not a physical emergency. It's typically an emotional and psychological emergency. And those kinds of problems need very, very different kinds of environments to help. So you need somewhere that's frequently calm, that's quiet, where the people who you meet are trained, willing, and able to address suicidality in a thoughtful, professional way. And that's often not the case in an accident emergency environment. It becomes really obvious when you flip it around in the other way and you say, well, if you were having a heart attack walking down the street, do you clutch your chest and make your way to your local counselling centre and expect them in there to be able to address your problems? You can imagine that if you're having a heart attack walking down the street, that going into a counselling centre is not the best environment to go with that problem type. So it becomes obvious that the skill set of those people there and that problem type don't really match. And the same is true for A&E, that the problem type of an emotional and psychological crisis and the skill set of the people there aren't particularly well matched, nor is the environment particularly conducive to dealing with that particular problem type. And that's despite the fact that there's often co-occurring physical emergencies. So, for example, if somebody takes an overdose, then obviously they need some medical attention as well. But that doesn't mean that it shouldn't just be a step along the road to the type of environment that is best able to manage emotional and psychological emergencies rather than the ones that are best able to manage physical emergencies. So when you go back to your question and you say, what do we need to do more broadly in society, I think we need to think really carefully about the kind of environments and the kind of help that we're giving people. I think we need to move it away from an illness focus and a medicine focus to a psychological and psychosocial focus, because that's where the problem type typically is. And build environments and train people to work in those environments in a suicide-specific way, using models like the CAMS model and others that have an evidence base for being effective. And if we do that, the chances are that we'll save more lives, that suicidal people will be treated with more respect and dignity, and that I can answer your question in a more straightforward way. And if you say, well, where should people go? And I would say, that's where you should go. But unfortunately, we don't have a lot of that at the moment. There's a few exceptions. Pieta House, I think, is doing a great job in developing a suicide-specific pathway for people. They're reasonably limited in the types of people that they can work with. So they can't work with all people who would be presenting for mental health care, for example. So they're not, they can't provide a replacement for mental health services. So mental health services do need to become suicide specific as well. I think that's a really important development that that our politicians maybe need to take kind of seriously, that our healthcare needs to take seriously if things are to improve.
Definitely. Yeah, definitely. And by psychosocial there, do you mean like the environment the people grew up with and they're currently in now, is it?
When I'm thinking about psychosocial approaches, I'm thinking about approaches that take into account the social circumstances you're in, whether that's current or historic. So it might include things like poverty, neglect, abuse, etc. And psychological would be things that are happening inside your mind, maybe things that are happening in your relationships or have happened in your previous relationships. And we know that these types of elements are really potent and significant in determining whether someone becomes suicidal or not. Yeah.
Okay. And then medication versus therapy. The medication is treating biology, and then the therapy is treating that psychosocial aspect. Would you say that's true, or?
Yeah, I think there's very limited evidence to for medication as a standalone approach to addressing suicidality, that the evidence base for effective interventions are largely in the psychological and the psychosocial realm. So the interventions that have more than one, so that's a replicated randomized control trial evidence for effectiveness, and that's a kind of a high bar, high standard of proof that the intervention actually works. The list of interventions on that list is very short. So you have CAMS, the Collaborative Assessment and Management of Suicide, dialectical behavior therapy, CBT for suicide prevention, non-demand caring follow-up, mentalization-based therapy. And then underneath that, you have a layer of interventions and therapies that have one randomized control trial demonstrating efficacy. So you have things like transference-focused psychotherapy, post-admission cognitive therapy, brief cognitive therapy, and there's some evidence that lithium in the bipolar group and clozapine in the schizophrenia group can reduce the suicide rate in those groups. So it's not that medication necessarily doesn't have a role, it's just that the overwhelming majority of data is pointing us in a different kind of direction. The difficulty is that when you have very poorly resourced mental health services, those other interventions are much harder to deliver in terms of the amount of time. So I think one of the kind of the backdrops to this, I mean, this is always true anytime you want anything to improve, but it can't not be said that if we want to do a better job in addressing suicidality, we need to take the resourcing problems in mental health care far more seriously than we've ever done before. Whether we put those resources into primary care or into other systems outside mental health care, and mental health care itself is another kind of debate. So there's a philosophical issue, there's a training issue, and then there's a resource issue. And if those three things are dealt with, then we could see a big shift in how mental health care is provided for suicidal people.
Is there any other healthcare providers that do a good job of this? I'm just personally interested.
I think there's pockets of good care in lots of different countries. So there's places in the United States, the Menninger Clinic, for example, which is an inpatient psychiatric service that uses the CAMS model as a standard mode of addressing suicidality. There are DBT-specific services in various jurisdictions in the UK, in Australia, etc. And then there are broader societal pushes on other kinds of approaches for addressing suicidality. For example, suicide prevention in the workplace, in particular groups. For example, the construction group in Australia, there's a program called, I think it's Mind Your Mates, and Working Minds have done a really great job in developing a kind of a program to shift culture around mental health care for people in the construction industry. So there's lots of layers to where you could put interventions, and there's lots of examples around the world. I don't know if there's any one country or jurisdiction that I would say, look over there, they're doing the best job, because I think most modern Western countries are struggling with the same kind of dilemma that we're struggling with here.
Okay. And so I have a question about you yourself as a therapist. So as opposed to dentists or surgeons, you're the instrument of care. There's a lot of responsibility that must come with that. And how do you deal with that responsibility yourself?
Yeah, it's a really rewarding role, and it's a very important role in a sense to working with suicidal people. But you're right, it's pretty onerous as well as in terms of responsibility.
Definitely.
And the being exposed consistently to the pain and suffering of other human beings does have a consequence for people. So we need to learn to experience that in a way that doesn't wear us out, burn us out. There's terms like compassion fatigue, for example, or vicarious traumatization, referencing some of the negative effects that you can have if there's too much exposure to the pain and suffering of others. So, I mean, it's true for most professional psychologists and psychotherapists that you would have your own psychotherapy. I've been attending my own psychotherapy through my whole career. To me, it's an ordinary part of coping with life, as well as a very useful addition to my role and processing the kind of work that I'm doing. I attend my own supervision. Outside of that, those kind of professional elements to managing, standard kind of self-care stuff, and never underestimate the relevance of laughter enjoyment, having fun with your friends, spending time with my kids. I try to keep up a reasonably frequent yoga and meditation practice, although, busyness sometimes gets in the way of that. And those things become really important to make that the kind of role that I'm doing sustainable. But I think actually they're really important for everyone to make life sustainable and to maintain some kind of sense of well-being in lives. Life is very busy and demanding for people these days. I think it's become very, very challenging to have what is often considered a fairly ordinary setup. With children and a house and all that kind of stuff comes a huge amount of pressure and strain. And there's this huge amount of demand on people's time, and demand psychologically in terms of our connectedness, for work, for example, that everyone's switched on all the time, that kind of idea, and that we really need to be very conscious now, maybe more than ever, of unplugging from those kinds of demands and providing other kinds of experiences for ourselves so that we can kind of stay centered and well within ourselves. It's very important.
Definitely, like everyone's very individual then in themselves in what they can tolerate stress-wise, and it builds up over time.
That's really true, and everyone has to learn what it is that helps them. And there's a kind of a different formula for everyone, depending on who they are and the type of environment they're in and where they are in their lives.
When someone close to you, or someone close to us, is either has suicidal thoughts or they're in therapy, for example, what are your recommendations for that person managing the situation, and how can they take care of themselves without playing into the burdensome feelings of the sufferer?
Yeah, so a few kind of basic ideas of do's and don'ts, let's say. So do take it seriously. So a lot of people who die by suicide have told someone prior to their death by suicide that they were thinking about it. Sometimes people are inclined to dismiss statements like that, sometimes based out of fear or sometimes based out of maybe being overloaded by things themselves and they can't quite take it in. So do take it seriously, and then not to panic, so staying calm. Try and figure out what the problems are that's pushing the person to be in that place. Let them know that you want to help, and ask them, have they thought about the types of help that might help? There's a lot of different ways to help with a lot of different kinds of problems. And there's many, many different types of approaches to helping with many different types of problems. So you could almost kind of say, well, let's sit down and figure out what the different kinds of help are, and we'll go through it. And another thing to do would be to make sure and follow up. So we'll create a kind of an arrangement where you say, I'm going to check in with you again tomorrow. If the person is able to and interested in seeking help outside of whatever the relationship is that we're talking about here, whether maybe it's a friendship or something like that, or a family member, that you can do some of the legwork around that, or you can support them in doing some of the legwork, finding out information, that kind of thing. Reducing access to lethal means is often a very important temporary arrangement. So asking the person, have they a plan? Have they got a rope somewhere? Have they got stockpiled pills, that kind of stuff? And getting a goodwill agreement to remove those from being too proximate to them for a period of time while they're in a suicidal crisis. And not to shame the person, not to get angry with them, even though those are understandable impulses, in a sense, that people get frightened when they hear about suicide. It's not supposed to be a comfortable subject. It's supposed to be a little bit troubling when you're talking with someone they're thinking about ending their lives. But to try and stay kind of centered and calm and compassionate towards their experience, and just letting them know that you're there for them and that you want to hear about it and that you want to talk to them again about it, and then follow up. So contact them the next day. You may also want to consider that a person may not feel that they can hold that kind of position themselves, and they might want to involve a professional or another family member or a parent if it's a young person. And that person who's trying to be the supporter of the suicidal person should be getting support themselves, preferably from somebody who has a little bit of ground or experience in navigating that kind of conversation.
So creating that community and support network around the person and the carer.
Absolutely.
Owen, thanks a million for coming on. Honestly, that was a great conversation. I feel like that will help a lot of people.
You're very welcome, Eoin.
And that brings us to the end of this episode. Let me know what you thought at Mental Wealth Pod on Instagram. Your comments are my cup of coffee. What I wanted to mention in the outro was something about a book I've been reading. I've actually been reading Carl Jung after hearing Jordan Peterson talk about him so much. He talks about dreams meaning a lot. Because they are a way of our unconscious mind representing our issues almost. So whatever is repressed by our consciousness can come up in our unconsciousness through dreams. So it's very much kind of a mystical and spiritual thing, as opposed to something that's actually solid and you can hit on with a hammer. But I love that shit. So I had a pretty crazy dream myself, and then reading this book, what the book is called, or is it? It is called The Portable Jung, edited by Joseph Campbell. And in the book, it breaks down a lot of Jung's ideas for the layman, me, and it's not for the fucking layman. Jung is insane. I cannot believe some of the stuff he was talking about in the ways he was talking about it. I'm going through it. I've tweeted about it at 10 pages an hour. I'm going back over and over reading like one paragraph 15 times just to try and understand it. But anyways, back to the dreams. I started having crazy dreams, and then with this kind of Jung vision that I've been having, because I tend to get wrapped up in the ideas of whatever I'm reading at the moment, I decided to kind of dig deep into my dream and what it might mean, which was pretty interesting. So what I did was I took my dream and I posted it on Reddit, of course. And yeah, so my dream was that I actually found myself in an underground tunnel with a notable author of Stoic related books, who's Ryan Holiday, and we were in a cavern. I'm going to actually just read this out. We were in a cavern that seemed to be holding ancient Stoic knowledge, like dreams do. You can be in a place and it feels like something is happening, but you don't know why. But yeah, it seemed to be holding like ancient knowledge. And then out of nowhere, the author was suddenly paralyzed. And I look up and noticed poisonous slugs all over the ceiling. And I was terrified and went over to tend to my companion. And then out of nowhere, I found myself in my childhood home. The same theme, goddamn Irish accent, the same theme of tunnels followed, except I found a tunnel out of my parents' room, and I felt compelled to take a trip into the unknown. So anyway, when I had this dream and I remembered it, I was like, okay, let's try and break this down with the Jungian dream interpretation stuff. But obviously I'm nowhere near intelligent enough to break this stuff down the way the Jungian psychotherapists do. So I went ahead and posted it, as I said, on Reddit, and this was one of the replies I got from one of the young guys. So he comes and says to me, okay, so I'm just going to read it out. Here we go. It looks to me like the author stands as a false guide to you. Your logical conscious side might agree to what the author's writing, but it falls apart when it encounters the reality of what is within. It also might not just be a writing, but a philosophy or way of life that you might think is good to follow, but it collapses when it tries to operate with reality. Imagine trying to calculate advanced physics phenomena just using basic algebra. The unconscious is trying to send you a signal, but you are clinging on too much to your current explanatory tools. Dreams also serve as a warning. It could also mean that if you continue clinging on to the current way of seeing life, it will eat you up inside. You trying to tend to your companion is what looks like to me as you are really clinging on to this certain way of seeing the world. You're trying to stick with WD-40 to fix everything. There are other tools out there, or you might not need any tool at all. The parents could serve as your ancestry. In you flows the blood of your parents and everyone before them. The way you could tap into that courage again is to be like a child. As the Bible says, blessed are the children, for they have faith. This makes sense as you want to have a trip into the unknown suddenly. Just like a child sees everything for the first time, you should let go of any ideas that are gripping your mind and see the world as it is. With love, with truth, and without evading whatever you might face, but of acceptance with courage. And as I read that sitting in a coffee shop, with my mouth agape, I was like, God damn, son. And obviously all of this stuff is very up in the air. It's down to interpretation, and I'd really recommend just reading up on Jung's stuff around conscious, unconscious, and collective unconscious, and then archetypes and all of this crack. It's so interesting. But yeah, I thought I'd insert that here in the end and and see what people thought. But yeah, that absolutely blew my mind. Anyways, guys, I leave you with that one. And actually, I might have a doctorate, like a professional young analyst coming on the podcast. If that's something that you'd like to hear, let me know again on Instagram at Mental Wealth Pod. But yeah, listen, have a great week ahead and fucking spread the love and stuff. Alright, till next time.